So this is a review of my talk. In the lateral review, there are some misinterruption and misunderstanding of the distance from the keel and the posterior cortex. Maybe this distance should be actually the distance should be shorter than the distance appears on the lateral X-ray because there's some tapering of the tibial metaphysis in the both AP and lateral view. So if the implantation is to medial, the distance can be shorter. So to recognize, to measure the real distance from the keel to the cortex, we need the CT scan. But actually, it is virtually impossible to take CT in every patient. Maybe this should be some tricks of the lateral view on the Oxford UKA. So, last my talk. Sorry. ちょっとあれね、コンサート行ってるから、ちょっと食べてくれへん。ごめん。Also, this I told about cementless Oxford. It should be very beneficial for the Western countries people because less frequent lateral lucency, the equivalent or even better outcome compared to the cementless. But in the Asian countries, maybe it is specialized in the Japan population. The fracture rate are incredibly higher than the fracture rate in the Western countries. This should be not a technical error, but it can caused by the special configure or morphology of the Asian people and small frame and osteoporosis. Basically, the most reason for this high frequent fracture can be attributed by the patient side factor, not operator factor. Because this is cementless, especially the cementless tibia is only limited to use for the skilled, experienced Japanese surgeon. Even in the skilled Japanese surgeon, the fracture rate is incredibly higher. So I summarize this result from our hospital. My colleagues just published in the Korean paper this the experience of the 155 cementless Oxford knee in 118 patients in our hospital from January 2016 to the April 2017. We experienced in this period the 6 fractures and 150 non-fractured patients. I believe that the morphology, especially for the proximal tibial vara, can be the main cause of high frequency of the tibial fracture. To evaluate the proximal tibial vara, we devised a new method to recognize the tibial vara. So this is the medial eminence line and MEL. So this is the MEL. So we draw the anterior axis of the tibia and connect the center points 6 centimeters below the joint line and 12 centimeters below the joint line. That should be the anatomical axis of the tibia on the short X-ray film. So draw the tibial anatomical axis and parallelly move this axis to medially until this line comes to the tip of medial eminence. So we call it medial eminence line. If this line pass intramedullary, medial to the medial cortex of the tibia, we call it the intramedullary type. So this is the normal morphology of the tibia without proximal tibial vara. So in contrast, if the line pass outside of the tibia, we call it the extramedullary type E. That means the proximal tibial vara. That can be the risk factor of the tibial fracture because there is a lack of a bone volume under the tibial component. So we compare the fracture frequency between the type E and the type I. There is a significant difference, the proportion of the two groups. In the extramedullary type has a higher fracture risk. So there is still the gender difference. The male patient have the decreased risk of the fracture. In contrast, female have the higher risk of the fracture. Maybe this is contributed by the time of the process of the female that is more frequent, more evident in the female patient. So we also compare the vara angle between the control group and the fracture group. So there was a significant difference between the control and the fracture groups. The tibial vara angle the higher value, but the difference was very small, only the 0.4 and 0.5 degrees. So it is virtually impossible to identify the patient have the risk or not preoperatively. So I recommend to use MEL, medial epicondyle eminence line, to identify the patient that has the higher risk of the fracture after the cement leg and even the cement teeth. And tibial vara angle is the higher in the patient with the type E, extramedullary type, in terms of the MEL. So then we published, just accepted the paper in the Bone Joint Journal. This is the multi-center study from the 6 hospitals and totally 212 patients, less Oxford year, using the MEL and evaluate the risk of a fracture. So this is the result. So we compare the fracture group and the non-fracture group. We found the gender difference. The male patient have the decreased fracture risk, and the diagnosis, OA, and necrosis, and age, BMI, FDA, HKAA. There was no difference between the fracture and the non-fracture groups. The only gender difference, but we are taking into account the morphology of the patient in terms of the intramedullary and extramedullary type. We found a very big difference between the fracture rate between the extramedullary and the intramedullary type. The odds ratio is more than 10 times. So the patient have the extramedullary type is 13 times higher risk of the fracture after the less Oxford. In addition, we found the patient have the small frame from the tibial side that needs the A or AA for the tibial side. The patient also had the increasing risk of the fracture. The odds ratio is approximately 7 times higher than the patient that needed the B or more or larger tibial size. So we combine the two conditions. So that if the patient has the extramedullary or very small, that means the very overhanging or medial condyle, or very small, that needs A or AA, has the very, very high risk of a fracture on the odds ratio was 21 times higher. This is integrally high risk. So we recommend not to use the cementless implant. And if, for the patient with the extramedullary type of the medial, that means the proximal tibial vara, or in other words, very overhanging the medial tibial condyle, or very small, so A or AA. Interestingly, for the Asian people, the chance to use the A or AA is higher than the Western countries. Maybe because this is because of the very small the frame compared to the Western country people. And we also found the correlationship between the small frame and extramedullary types, the very overhanging or the medial condyle. The very small patient have the higher chance to having the extramedullary type or very overhanging or the medial tibial condyle. And similarly, the female patient have the higher chance to have the extramedullary type. And of course, the female patient have the higher percentage of the patient, the tibia that have the very small. That means the tibia needs the A or AA. So because the female is smaller than the male in general saying. So we are very we should remember the female patient is a higher risk of fracture, and extramedullary type, the very overhanging or proximal tibial vara, the patient have the higher risk of the fracture, and the small frame patient have the higher risk of fracture. So for that patient, we need to use the cemented tibia instead of the cementless. So to identify the risk of the fracture, we recommended to take the true AP view and compare just after the operation on 1 week and 2 weeks. Then you should focus on the distance from the vertical cutting tibial cutting plane on the lateral surface of the lateral wall of the tibial tray. Initially, there is no space between the bone and lateral wall of the tibial tray. But in some patients, we can see some space between the bone cutting surface and lateral surface of the tray. So then after that, we sometimes find the fracture. So maybe typically this separation we can find the 1 week post-operatively, and then generally the fracture occurs 10 days or 2 weeks after the operation. So So we need to find this side, the separation of the bone and lateral wall of the tibia tray. We named it the takeoff sign. So if you find takeoff sign, you should control the patient weight bearing. You should restrict the patient not to not to work in the for weight bearing. So in this at the time in the B, if you stop the patient to weight bearing walking, so the fracture can heal unevenly. So maybe you should surprise some patients how some takeoff fine, especially after the 7th leg Oxford knee. So it is a very important sign. But to recognize this takeoff sign, you should take the true line. It needs a fluoroscope control to just alignment the flexion and the extension of the tibia. Sorry. So to one solution is to use the cemented component. But even the cemented component, we sometimes experience the fracture after the for the knee. So the patient might have the tibial vara or very overhanging on the intramedullary type on the small side. So in this patient, another solution is to cut the tibia in the varus. Varus cut can increase the distance from the keel and the medial cortex. The close distance of the keel and the medial cortex is shows the higher risk of the fracture. So in this patient, I recommend to cut the vara in varus. And in addition, we should cut the varus so we can use the one size bigger size of the tibia component, because the distance from here to here is the longer if we implanting the component in varus. So because why the cement lace is so have the higher risk of the fracture, unlike the cemented, to get the initial fixation, the cement lace component need to the interference. That means the impaction of the keel into the bone. To achieve this, this width of the slot for the keel should be narrower than the thickness of the keel. Then we impact the tibia tray. The initial fixation or the secured initial fixation can be achieved, and subsequently biological fixation of the tibia and the bone. But this is a very problematic. If the bone quality is very poor, or the distance from the keel to the medial cortex is very close, that can cause the fracture. So the one simple solution is to avoid the cemented component. But after the cemented component, we sometimes experience cemental fragment, especially for the backside of the tibia component. And sometimes we can see the labial-lucent line between the bone and cement. That can be misinterpreted as the loosening. So that can cause the unnecessary revision after the Oxford knee. To avoid this, if we use the cementless component for the tibial side, so the rate of the occurrence of the radiolucent is lower than the cemented component, but less radiolucent, but higher percentage of the fracture. So it is very quite difficult to use in the Asian countries. So another solution is enlarge the slot of keel using the cemented peak of the cheese for preparation of the keel slot for the cemented. So this is width of the cemented peak is a little bit narrower than this one, the width of the cementless component. Because unlike the cemented component, in the cementless component have the porous coating and hydrogen apatite coating on the keel surface. So the width can bigger, wider than the cementless, cemented one. So this is a treatment. This is a treatment strategy provided by the Oxford group. Because of the most fracture is occurred from the tip of the keel and the adjacent medial cortex or the tibia. So this fracture line is proximal to the attachment of the medial collateral ligament. So this medial side stability can be secured in most cases. So we do not worry about medial instability due to the insufficiency of the MCL. So we already consider to the bone union and residual valgus deformity due to the depression of the medial joint surface. So we can categorize the case into the 4 cases. This is a united or ununited case. Sometimes we can see the patient where the fracture has already fused. So of course there is some depression on the residual varus. But if this varus is acceptable, so the patient will be happy, no pain, slight varus alignment. But it doesn't matter. But this varus is not acceptable. So we need some revision to the TKA is necessary. But once the fracture is united and event-free, most patients can accept the varus alignment because the patient is very happy to the no pain, they can work. So, but in most cases, we can find the fracture just after the occurrence of the fracture. So if the varus is acceptable, we can treat conservatively the patient, the fracture. Maybe I treated this type of fracture or 3 or 4 cases without the operation. So one reason is patient denied the additional operation, or fracture is very, very minor, just on the clot. So it can heal and event-free after without the surgical intervention. But sometimes, so we fix the fracture using the buttress plate in the medial side or a simple cannulated screw. in the case without the displacing of the fracture. And after that, because most of patients have the osteoporosis at that time, I add teriparatide, TDH, low dose VGH, and ultrasound like that. So, and this balance is not acceptable. So we have two choices. One is or reef. So reduction of the fracture and internal fixation. And TKA. Maybe this is depend of the type of operation and type size of the fracture fragment. Or sometimes this fracture can occur just after the medial placement or lower placement of the tibial tray. At that time, there is partially no space to bone union. In that case, I gave up the bone union because of the lack of the bone volume to heal the fracture. And at that time, I convert to the TKA. And if a fragment is enough large and the patient accepts some weight control after the operation, I try to fix the fracture after the reduction, the both closed and open reduction. In the near future, I will summarize that treatment strategy, and maybe I or my colleague will write a paper regarding this. So this is a treatment strategy, and today I talked about the cementless risk of cementless. The higher risk for after the cementless Oxford should be the tibial vara and the small frame and female gender. And take care. You should find. You should you don't miss the takeoff sign, the separation between the vertical cutting surface and the lateral surface of the tibial tray. And the third is the treatment strategy. The conservative treatment or also synthesis, or sometimes it's effective, successful, but it depends on the patient demand and size of the fragment of the medial condyle. Okay, this is the end of my talk. So I will continue my talk a little about treatment. I will show you our case after the fracture and how to manage it. I will show you in next week. So please come and join in the next Tuesday from 8:30 p.m. in your country and 9:30 in our country. Thank you for joining me, and I'll see you and have a good night. Bye.